West Florida Atlantic University and is actively involved in advancement of colorectal surgery on national and international level. Today he is going to speak on consensus statement by International Society of Fluorescence-guided surgery. Over to you, Dr. Wexner. Welcome.
Thank you very much. I'm very pleased that I'm able to participate in the meeting and that I can do it remotely because I need to be here for my own course starting in a couple of days. I'd much prefer to be there. I love traveling to India. I was just there a few months ago and looking forward to my next trip, but thanks for indulging me today. Let me look to share my screen here. And I'll get my talk up. Okay, so you should be seeing my slides now, and there'll be a little redundancy with what we just heard. So although I'm speaking about the consensus statement, I've put in a couple of other things as well to go along with that consensus statement. So we just saw a beautiful video and a great talk with lots of data. Many of those articles, I was a co-author, including the Pillar 2 trial, the Mizrahi paper, and others. So I've been using ICG for probably 15 or more years by now. Why? As we just saw, it's a great tool. It's really the only quantifiable tool, if you will, for perfusion assessment. It helps us visualize anatomy. There are other uses we've not yet explored: tumor localization of hepatic and peritoneal metastases, higher definition for pelvic node dissection, for sentinel node identification mapping, as well as routinely for ureters as well. Saw some of these data, incidence of anastomotic leaks. As we look through randomized controlled trials around the world, we see anastomotic leak rates generally from 10 to 15% for the type of anastomoses under discussion, and that's a problem. Anastomotic leaks have a very high cost, not only the 30-day morbidity and mortality, but then continued poor health-related quality of life. And we heard about the holy grail of avoiding stomas, and here, unfortunately, patients end up with an increased risk of permanent stoma, up to 100% actually in some series, when they've had anastomotic leaks. So something we must assiduously avoid. There's financial costs too. And you see, depending upon the currency, the common denominator is it's a lot of money, and there's no healthcare system in the world, India, US, or otherwise, that can afford to keep paying for anastomotic leaks. Finally, there's the cost of the oncology, that there's a higher rate of recurrence and a lower survival rate, higher mortality when somebody's had cancer and a leak. We just saw this study in which I was the top enroller for this Pillar 2 trial, and we saw that for low-risk anastomoses and high-risk anastomoses, both is incredible efficacy. You can see that our high-risk anastomoses are under 10 centimeters, patients with a radiated pelvis or both. And just like our study, Frederick Riss from Geneva also showed 2.4% anastomotic leak overall, including for the high risk 2.3%. So, now we're going from 10 to 15% leak, albeit in non-randomized controlled trials, both in our U.S. Pillar 2 trial and in this amalgamate trial from Geneva, Oxford, and Ireland, showing leak rates of 2.4%.
Mr. Wexner, your slides are not moving.
They're not moving.
I think you did not. You might have shared, but you are not playing it.
Oh dear. Okay. Well. Oh jeez.
That's okay.
All right. Let me try and go back. I wish I'd known that a few slides ago.
Perfect. Perfect.
So it's not showing it on.
Yeah, it's okay now. It's okay. It's okay now.
But what's the last slide you saw? Did you see this one?
Yeah. Why use ICG? Yeah. And then you're in some data. Yeah. Okay. Here.
Tell me where to start again.
The incidence, yeah. You can start from incidence.
Start from incidence. So,
yeah. Okay.
Incidence of leaks in contempt, so then I'll leave it on this mode instead, because I suppose it's, whatever the reason, the other one's not working well. So incidence of leaks, as you can see, and let me just move this little thing over so it's out of the way, perhaps. It won't move. I can put it there. Okay, incidence of anastomotic leaks. Let me just try once more. Tell me if this works with full screen mode, because it really is better. Do you see it there? Can you see the slide?
Yeah, we can see the slide. We can see the slide, yeah.
Okay.
Yeah.
Let me advance it and see what happens.
Okay.
Can you see the one?
You can click one by one. No issues. You can click one by one. No problem.
Do you see cost of anastomotic leaks?
No. We are at incidence.
I don't know why it's not shown. Okay, all right, then I'm going to leave it on the other non-present. I'll leave it like this.
Now it's visible. Okay, okay.
Yeah, okay. So the bottom line is the cost of leaks is great. Morbidity, mortality, health-related quality of life, and as we just heard, the holy grail is avoiding even temporary stomas, and here we're looking at an increased risk of permanent stomas. A very expensive proposition financially and oncologically, with increased rates of local recurrence and decreased rates of survival. The Pillar 2 study was the first one, non-randomized. We published it 11 years ago. We did the trial probably between 12 and 16 years ago, something like that, looking at high risk and low risk anastomoses. And it was a feasibility study, and you already saw the punchline, you already saw the result, but here's the change in the surgical plan. So if you look at the 7.4%, or 7.5% and 1.8%, you come up with 10.3% overall, and then you add that to the leak rate we had, and that gets you in the 10 to 15% range, right? So our leak rate, which was around 3.5% in the high-risk anastomoses, when you add to it these changes, you could postulate a much higher risk for leak without ICG. And Frederick Rist found the same in his study, which was retrospective amongst surgeons in Oxford, Geneva, and Ireland, where for high-risk anastomoses, low anterior section, he has 3.3%. So we had about 3.4% in Pillar 2. We had 3.3%. You saw a different study by Mizrahi. This one was 2018. So even as of 7 years ago, looking at the data from Luigi Boni, from our study, from Kim, there was almost a consensus from the literature favoring ICG, and I'll take you through the journey of where we go with that. But the more studies come out, the more incidents. So a couple of years after our meta-analysis systematic review, we come out with pretty much half the rate of ICG, mainly in the high-risk anastomoses, and that's where we really want it. So that gets us to the consensus statement. So this was done in two parts. So the first was a group that we met in 2019, in around October, November 2019 in Frankfurt, Germany, through the International Society of Fluorescence-Guided Surgery, which is an international, as the name implied, multi-center group. So you have surgeons here from all over the world: plastic surgery, vascular surgery, thoracic surgery, cardiac surgery, HPB surgery, peritoneal surface malignancy, colorectal, upper GI, and the like. Lots of people, even scientists who are not surgeons. And we did this Delphi conference based on that Frankfurt meeting. And you can see, yeah, there's the date, September, okay. September 2019. We had basically the 44 questions. All statements and questions were pilot tested by a psychometrician and a statistician, and then we advanced in our consensus. We ultimately had 19 eligible voters throughout the world. We reached consensus in 93% of all the questions and 100% on the items relating to safety and effectiveness. So let me show you those. So yes, it's safe. In general, the use during surgery should be considered very safe, right? Slightly different questions. It's not adding the cost. And that's a very important one for the third, particularly in healthcare systems in India and elsewhere, knowing that you're not driving up costs. But as you go down that list and you come to the ones where there was no consensus, like informed written consent. Should we ask the patient individually, we're going to use ICG? Now, I do, but not for their permission so much as to be sure they don't have an allergy to iodine or shellfish, because there's a certain cross-reactivity with ICG, and anesthesia needs to know that. So as we go through this, you see all of these consensus, and you can look at the article in Annals. I don't have time to go through each one, but you can see tremendously high consensus. So basically, to summarize that study, it's effective, it's very safe, and as we just heard, you have to flush it through quickly, and you have the issues relating to focal length of the camera that we just heard about and the like. Some different opinions about written consent and when people should learn to use it, although in this day and age people are learning in medical schools. Cost is not a barrier. So then we went on to do specialty-specific consensus statements, as you can see on this slide. And as editor-in-chief of surgery, I was pleased that we were able to get these articles as a special issue in surgery, a supplement issue in surgery in December 2022. And you see here the different topics. So colorectal is one of them, starting on page supplement 38. So how did we do with the second survey, in which we limited, and you can see the names of who participated there, many people you'll recognize from around the world. How did we end up with these 35 international experts and 69 statements for colorectal surgery? And even though we ask about shellfish and iodine, it turns out that it's very rare. So this statement moved up, but this consensus was done after the original one in Annals of Surgery. So more and more people realize it's important to ask about it. But also we start getting into some nuances, like should you use with pregnancy or without pregnancy, even the fact that is it an absolute contraindication, and it's not. It's like if a patient needs a CAT scan with iodine, intravenous contrast, you pre-medicate them. So as long as anesthesia knows, it's fairly safe. But you could look in this issue of surgery and see a lot of the nuances. Now, here's an interesting one on the top of the slide. We don't routinely use it for the right colon, like in ileocolic resection and anastomosis, because that's a very robust blood supply. But there's absolute 100% in round one that if there's any question of right side anastomosis, it should be used, and there's no doubt. And moreover, the left side, 96%, one person saying it wasn't necessarily all of the time, but very high rate of consensus in round one. So left side becomes routine, right side becomes sometimes. The timing is important. It flushes through very quickly. And as we just heard, you do need to flush through with 10 cc's of normal saline. We don't yet know about lymphatic identification. We need to learn how to do that, whether to try and inject into the peritumoral area. If so, at what point we do it and what dose. We haven't worked that out yet. Interesting, we found that in some cases there's not that beauty we just saw in the video. So in some cases, and I thank you for putting this talk after that one because it makes it easier to explain. If you don't have adequate perfusion, you should try to repeat it, be sure all the equipment's working, all the manufacturers, Stryker, Storz, Olympus, Medtronic, every single system, Intuitive, has fluorescence capability. But with some of them, you can change the gain and the intensity and you need to be careful that it's in the right setting. Everyone agreed it's essential to train residents, and we all agreed that it's continued to increase. We don't have an internet. It's interesting, even though we are here 3 years after this publication, or 2.5 years after this publication, we don't yet have consensus about this, or we don't have the registry, even though there's consensus that we should. There have been several other consensus besides the one we published, or the two we published from the International Society of Fluorescence-Guided Surgeons. This one is from the European Association for Endoscopic Surgeons. ICG is associated with a reduction in anastomotic leaks. Absolutely, because if you now look at that plot on the right, unlike the one we published in 2018 from Mizrahi as first author, 5 years later, now all of those studies out there, you add a lot more. Certainly ours, the Mizrahi study from 2017 that we saw, the Mizrahi study from 2018, Antonino Spinelli, Jun Watanabe, and many others. Now suddenly it is absolutely advantageous where we haven't hit that holy grail that we just heard about. So even though we're reducing complications and length of stay, we're not increasing operative time, still we're not there. We haven't yet hit the holy grail that we just heard about to avoid making stomas. Similarly, from Asia, we see huge differences. Anastomotic leak rate, 16.5% versus 3.5%, and a tenfold difference in admissions. So really, really huge, not at all subtle. It's not advancing at all. For what we're offering the patient. I think there's a little overlap here with what we just heard, but for the Essential trial, which is the largest randomized controlled trial out of Japan, and you can see particularly ICG group versus non-ICG group, clinical anastomotic leaks 4.7 versus 8.2%, reoperative rates 0.5 versus 2.5, so five-fold difference in reoperative rates when using ICG, the AVOID trial, and we just saw anastomotic leaks, 7% control versus 9%, but for whatever the reason, they used right-sided surgery as one of their groups, and I don't quite understand why, because when you limit to what we had the Pillar 2 trial meant to show, the pillar was for left-sided and low anterior section. Okay, so that's perfusion of left-sided and low anterior section. Here they have rights. When you limit it to our initial intent of left-sided, there is a significant difference in this trial, although there's not when you look at everything all combined. So then we get a new meta-analysis, the last one, and this was just done by Nir Horesh, one of my current trainees, looking at all the newer studies, so the 2020 through 2024. Now this study is the Pillar 3 trial, and although I authored the trial, I didn't participate in it because of working at that time as a chief medical officer for Novadak, which became acquired by Stryker, and I didn't participate in the trial. But unfortunately, the trial was prematurely terminated, so they never hit their enrollment denominator of patients, and I think that's why their result is different than everybody else. But nonetheless, despite one negative study due to inappropriate premature termination of the trial, you can see we maintain now that it is beneficial to use ICG. So that's the consensus statement, and that's some of the data surrounding it. And here's why I'm not with you now, because I need to be here getting ready for my annual international colorectal disease meeting. And we hope to see some of you here later in the week. I know we have had the opportunity to raise a lot of philanthropy and have quite a few surgical scholars coming from India to be with us. I hope I'll see some of you there. I can stop sharing the screen and answer any questions.
Thank you, Mr. Wexner. For your illustrated presentation. Do you still follow those Kelvin-Dindo classification for its morbidities?
For complications, it helps. We don't do it on an individual basis, patient by patient, to say that this is Kelvin-Dindo, 1 or 2, but we do when we're writing research, when we're collecting data. Like for the purpose of morbidity and mortality conference presentation, we wouldn't say this is Kelvin-Dindo XYZ, but we do when we're writing research. It makes the most sense.
Okay, any questions from the audience? We have a question from Dr. Deep Goyal. He's a practicing general, this gastrointestinal surgeon.
I know him quite well.
Okay.
Steve, thank you for a lovely talk as usual. Just a comment, and I think you can verify that. I think there is a huge learning curve before you start interpreting ICG. As you very rightly said, the equipment should be working, the systolic blood pressure should be good, you should know how to use, how much dilution. So I find in my practice that it took me quite a while before I could understand how it works. Is that true in your practice as well?
No, I actually, when I think about some of the things I've learned in my career, like laparoscopic J-pouch surgery and transanal total mesorectal excision and other things, this one is surprisingly easy to learn. And I think there's very good consensus about where the green turns non-green. Having said that, you're right in the point of troubleshooting. So when the anesthetist injects, in my case, I generally give 3.5 cc's of ICG and then a 10 cc flush, and I assess it usually 30 to 60 seconds later, with the focal length being the appropriate distance. So if it's intracorporeal, a 30-degree lens. If it's extracorporeal for some reason, 0-degree lens. And the troubleshooting part, like it's not turning green, or it's really not as green as we like. And that's when the learning curve comes in. What is it you need to look at? Was the blood pressure adequate, as we just heard? Is the patient on pressors? Did anesthesia really flush it, or did they just open the IV for a couple of minutes? Are the settings correct? Because sometimes you look at the camera and one of the nurses pushed a button and suddenly it's on hysteroscopy or arthroscopy on the tower.
Right.
So that's the learning curve. Yeah. And it's very helpful to have a rep from the company in the room with you when you're first learning to use it. It's interesting though, because in terms of picking the right margin, so Ronan Cahill in Ireland asked me to participate in a study. I don't think it's yet been published, but he asked a whole lot of us. They sent videos around with an interactive software, and they asked us pick the spot you would select for the anastomosis. And there's surprising variability even amongst people who are highly experienced. It may only be by a couple of millimeters one way or the other, but that could be the difference of a leak and no leak. So what I like to do is generally go at least 1 centimeter into the green for my anastomosis. There's no question. If I say to myself, this is the transition point here, then I'm going to pick here for my anastomosis. And I think that's part of the way to get around that variability.
Thank you.
Now, ultimately, it's going to be quantified, by the way. All the companies are working on algorithms, so you can say this, put a number with the perfusion, and then you'll know. That's where we need to go.
Thank you, Dr. Steven. We highly appreciate your early morning contribution. I'm sure in coming days, image analysis by AI will be certainly contributing in the analyzing your immunofluorescence image. Thank you very much for your contribution. Okay.
Thank you.